Urologist, what research actually says about frequency and health for men over 60, Dr. Emily. Men over 60 often wonder whether there's an ideal frequency for this specific activity, and the honest answer, based on actual research, is more nuanced than any single number circulating online. Today, we're reviewing what studies actually show about frequency and health outcomes in this age group specifically, what changes physiologically with age, and what genuinely matters more than hitting any particular target. Research in this area reflects population averages, not individual prescriptions. The frequently cited figure of 21 times monthly comes from a single large population study examining prostate cancer risk. And even within that study, benefit appeared across a range of higher frequencies, not a single precise target. Evidence level, moderate, based on large observational data rather than randomized trials. Before continuing, a brief note, nothing here suggests men need to hit a specific number to be healthy. Individual variation is normal and expected, and this reflects patterns worth understanding, not requirements. The research most directly relevant here found men with higher frequency across adulthood had a measurably lower association with prostate cancer risk later in life. This is association, not confirmed causation. Proposed mechanisms include clearance of prostatic fluid and reduced inflammation, though these remain incompletely confirmed in humans specifically. The refractory period, recovery time before renewed arousal capacity, lengthens naturally with age, tied to hormonal shifts and nervous system changes rather than reflecting dysfunction. This means a pattern that felt natural at 30 will genuinely differ at 65. And comparing your current pattern against your own younger years rather than against population averages is a more reasonable way to evaluate whether something has meaningfully changed. We're now roughly halfway through, and this is where population data gives way to more individual, clinically relevant factors specific to this age group. What the research more consistently points toward isn't hitting a specific number, but avoiding very long-term sustained absence over years specifically. A temporary gap isn't what this research describes as concerning. Comfort, avoiding rushing due to anxiety, and using adequate lubrication given age-related tissue changes matter considerably more for actual well-being than any specific frequency target. Several conditions common in this age group directly affect frequency and comfort. Prostate surgery, depending on type, can affect function. Certain medications, particularly some blood pressure drugs and antidepressants, are documented to affect interest or function as a side effect. Diabetes affects nerve and blood vessel function relevant here. A sudden change rather than a gradual one warrants raising with a doctor rather than assuming it's simply expected aging before continuing. If you want a broader framework connecting hormonal health, sleep, and vitality after 40, Dr. Emily Carter's guide, The Iron Age, The Complete Blueprint to Reclaiming Testosterone, Strength and Vitality After 40, covers testosterone, strength, energy, and vitality across 9 focused chapters in a concise 14-page format. It's priced at $49.99 with the link provided with this video. It's educational, not a replacement for medical care. Reduced natural lubrication and tissue changes with age mean adequate lubrication matters more than it did decades earlier. Reducing friction-related irritation, rushing due to anxiety about maintaining function activates a stress response that works against the process itself. Slowing down and removing time pressure tends to produce better outcomes and reduce discomfort. Bringing this together, there's no single ideal frequency supported by research, only broad patterns suggesting consistency matters more than any specific number, and very long-term absence over years carries the most consistent research association worth understanding. A sudden change, pain, or discomfort warrants medical evaluation, not self-diagnosis. Comfort and adequate lubrication matter increasingly with age. Survey research examining frequency across age groups consistently finds a gradual average decline from a peak generally in the 20s and 30s through subsequent decades. This reflects several converging factors: gradually declining testosterone, lengthening refractory periods already discussed, and general health changes accumulating over time. It's worth emphasizing this is a population average, not a prescription for any individual man. A man in his 60s with a pattern matching the average for men in their 40s isn't experiencing anything abnormal purely based on that comparison. What research finds more clinically useful than comparing against a population average is tracking whether an individual's own pattern has shifted meaningfully relative to his own baseline and whether that shift is accompanied by other symptoms. A gradual, modest decline over years, consistent with the broader population pattern, differs meaningfully from a sudden, significant drop occurring over weeks, the latter being considerably more likely to reflect an identifiable, addressable cause. Erectile function, closely tied to this broader topic, depends fundamentally on healthy blood vessel function. A man experiencing a gradual, unexplained decline tied specifically to reduced function rather than reduced interest may be observing an early signal of broader cardiovascular changes worth investigating, since the small blood vessels involved here are often affected earlier in disease progression than larger vessels responsible for more commonly recognized cardiac symptoms. This is precisely why a persistent function-related change deserves genuine medical attention rather than assumption that it's simply an unavoidable part of aging. Chronic stress and mental health directly influence both frequency and the subjective experience of this activity. Elevated cortisol from chronic stress can measurably reduce interest over time, meaning a change sometimes reflects an underlying stress or mental health pattern worth addressing directly. Depression specifically is well documented to affect libido, and certain medications, particularly SSRIs, are independently documented to affect both interest and function as a known side effect. A change accompanied by low mood or fatigue points toward investigating mood as a potential underlying factor, rather than assuming the change itself is the primary issue. The distinguishing factor based on clinical frameworks used in this area generally isn't frequency itself, but the presence of distress, compulsivity, or meaningful interference with daily life. A man engaging in a pattern he finds comfortable, that doesn't interfere with responsibilities or relationships, and that he doesn't experience as distressing, doesn't meet criteria for a concerning pattern regardless of frequency. Conversely, genuine distress or a sense of compulsion, regardless of the specific frequency involved, may benefit from discussing this with a therapist specializing in this area. Building further on the medication point raised earlier, it's worth walking through specific categories in more detail, since understanding the actual mechanism helps explain why these interactions occur. Beta blockers, commonly prescribed for high blood pressure and certain heart conditions, work by blocking adrenaline's effects on the body. While effective for their intended cardiovascular purpose, this same mechanism can reduce blood flow responsiveness in peripheral tissue, sometimes affecting function in ways patients don't immediately connect back to their blood pressure medication specifically. Selective serotonin reuptake inhibitors, a common antidepressant class, are well documented in clinical literature to affect sensation and function as a known side effect, sometimes reducing sensitivity considerably. This is a well-established, frequently discussed effect within psychiatric literature, meaning it's a legitimate topic to raise with a prescribing doctor who may have alternative options within the same medication class, carrying a lower likelihood of this particular effect. Medications for enlarged prostate, particularly alpha blockers, work by relaxing smooth muscle to ease urinary symptoms, but this same relaxation mechanism can affect ejaculatory function as a secondary effect for some men. None of this information should discourage necessary medication use, since the underlying conditions being treated are themselves significant. It's meant to help men recognize when a change might be medication-related, often opening the door to a straightforward conversation about alternatives within the same class. Alcohol deserves specific mention, since its effects are frequently misunderstood in this context. In small amounts, alcohol can temporarily reduce inhibition. Physiologically, alcohol is a depressant that directly impairs blood flow regulation and nervous system signaling, meaning regular or heavier consumption is well documented to reduce function over time, separate from any effect on interest itself. Chronic, heavier alcohol use also independently lowers testosterone through effects on liver hormone metabolism. A man noticing a gradual change alongside regular, heavier drinking has a genuinely identifiable, modifiable factor worth addressing directly, often producing noticeable improvement within weeks of meaningfully reducing intake. Smoking carries similarly well-documented relevance given its established impact on blood vessel health throughout the body. Nicotine constricts blood vessels, contributing directly to the same arterial changes discussed earlier regarding cardiovascular disease and function specifically. Research consistently finds smokers experience measurably higher rates of difficulty compared to non-smokers of the same age, an effect that improves sometimes substantially following smoking cessation, since blood vessel function shows genuine capacity to improve once the ongoing damage from smoking stops. This represents one of the more directly modifiable factors discussed throughout this video. Body weight and metabolic health connect to this topic through multiple overlapping mechanisms. Excess body fat, particularly around the abdomen, increases activity of an enzyme converting testosterone into estrogen, directly lowering effective testosterone. Obesity is also independently linked to increased rates of diabetes and cardiovascular disease, both already discussed as relevant to function specifically. This creates a pattern worth understanding. Weight, blood sugar, cardiovascular health, and testosterone are deeply interconnected factors rather than separate systems, meaning addressing weight through sustainable, moderate changes often produces improvement across several of these interconnected areas simultaneously. It's worth noting a nuance sometimes missed in health content generally. Extremely aggressive caloric restriction or excessive exercise volume adopted suddenly can paradoxically suppress testosterone and reduce function further, at least temporarily, since the body interprets extreme caloric deficit or excessive physical stress as a signal to deprioritize reproductive hormone production in favor of immediate survival functions. This is precisely why sustainable, moderate approaches to weight and exercise tend to outperform extreme, rapid interventions when it comes to the hormonal and vascular systems discussed throughout this video. For men in long-term relationships, frequency and interest are influenced by relationship dynamics themselves, separate from any physical factors discussed throughout this video. Research on long-term relationships consistently finds frequency naturally shifts with relationship duration, life circumstances, and satisfaction, reflecting normal relational dynamics rather than purely individual physiological change. A change within a partnered relationship isn't always best understood by focusing exclusively on individual physiology. Relationship stress, or simply the natural evolution of a long-term partnership, can meaningfully influence this picture, sometimes more significantly than any single physical factor, bringing together several threads discussed throughout this video. It's worth offering a genuinely practical framework for what to do if you notice a significant unexplained change. A reasonable starting point involves considering recent changes across several categories: any new medication, recent significant stress, changes in sleep quality, changes in relationship circumstances, and any other new physical symptoms. Identifying whether the change coincides with any of these factors often provides a useful starting point for understanding the likely cause. If no clear explanation emerges, or if the change is accompanied by other concerning symptoms, fatigue, mood changes, or changes in erectile function specifically, that combination genuinely warrants a conversation with a doctor, ideally including basic blood work checking testosterone, thyroid function, and blood sugar. So here's the bottom line. There's no single research-backed ideal rhythm, and treating this as a rigid target misses what the evidence actually shows. 3 practical takeaways. Focus on consistency relative to your own pattern, rather than a population number. Use adequate lubrication given normal age-related tissue changes, and raise any sudden change or discomfort with a doctor, rather than assuming it's simply aging. If this addressed something you'd wondered about, that's exactly why this video exists. The Iron Age Guide is linked with this video. Thanks for watching, and I'll see you in the next one.